Hi everyone, welcome to today's presentation by a Physician's Cup of Coffee, the 5th in ABG Masterclass series and the 4th of ABG Problem Solving. Over the years, I've gained so much from so many. Some amazing people in my life who have cared with boundless love. Eternally grateful I am to them. I'm also thankful to the teachers who have given without holding back. So, can I give something back? I certainly hope so. Hopefully, this will be helpful to some young physicians in their clinical journey and in their exam preparations. That for me would be amazing. As discussed in the previous videos, this would be the process we would be following and it would lead you to the right assessment. As mentioned previously, this would be all of the results if not mentioned specifically. Alright, let's begin with interpreting this ABG scenario. Can you identify anything in particular? I actually would say that this scenario actually has got a triple disorder, and we could discuss something else as well. Let's see. The pH is on the higher side, the PCO2 is on the lower side. I would straight away say respiratory alkalosis. Then I would look for the compensation. I would expect the bicarbonate to come down, but the bicarbonate here is on the higher side. So additionally, there is a metabolic alkalosis. And then, as mentioned previously, look at the electrolytes. Look at an anion gap. Here you would say that you got a HAGMA. So straight away within a minute, we've diagnosed that this ABG scenario is suggestive of a triple disorder. Yeah, now looking at the results, this is how I would interpret, and we come to an assessment of the patient having a triple disorder. Right. In addition, looking at this particular, this is actually an MCQ scenario, you would actually say that this particular patient might have what we would suspect what's called a Pendred syndrome. What that is, that's actually a defect in the beta intercalated cells of the collecting duct, cortical or medullary collecting beta intercalated cells. And when you have a pathology there, you could have what is called as a Pendred syndrome. Okay, we would actually discuss this later on when we do renal physiology, but just want to mention that. So that was the actually answer provided by the course provider as well, just for your information there. They followed a different approach, but that's the answer. I mean, you know, different people have different approaches, but the method that I mentioned is what I follow, and I've always reached at the assessment that other people have reached as well. It's up to you to decide what you want to do. Looking at the next scenario, the pH on the lower side acidemic, PCO2 on the higher side, so straight away I would assess a respiratory acidosis. I do not know whether this is an acute or chronic based on the scenario description, but if it is an acute situation, I would expect the bicarbonate to be at least 25. A chronic situation, bicarbonate expected to be at least 29. Here it's actually way low down, indicating that there's likely a metabolic acidotic process going on as well. So thus far we have identified a dual disorder. However, there is a possibility of a third disorder. We cannot assess that because we don't have the electrolytes to do an anion gap calculation. Looking at the PO2, we notice that hypoxia. So this scenario would benefit from doing an AA gradient. That's something we could discuss later. So that scenario actually doesn't tell us whether it's an acute or chronic. whether we could work that out from the given information is the skill that we have to see whether we've got. Okay, I've actually on the previous video, the last slide very clearly actually explains that as to how a medical registrar could make use of that decision into incorporating that into his decision making process of moving a patient to either to the ward or the intensive care unit from the ED. I'll explain that in the next slide as well. So to find out whether it's an acute or a chronic respiratory acidosis, we use the delta PCO2 and we use the correction factor for acute and a different correction factor for our chronic respiratory acidosis. Making use of those factors, we could identify what would be the pH if it was a pure chronic respiratory acidosis and what would be the pH if it was a chronic respiratory acidosis. And if the patient pH fits either one, then we would say that is what patient does have. But if the patient's pH is between an acute and chronic, then we would go and assess the clinical situation to see whether the patient's got an acute on chronic respiratory acidotic situation. And this entire process has been clearly demonstrated in the previous video, the last clinical scenario example as well. It's a very useful skill to have. Before we proceed with this particular ABG scenario, I would like to say that this is taken from an article in the American Journal of Kidney Diseases by the authors Fenvers and Emmett, whose name I've actually mentioned and shown here as well. It's an amazing article. Have a read. There's a lot to gain from that. Okay, so shout out to them. That's an excellent article. And this scenario, a particular scenario, I've taken because there's a lot we can learn from this as well. So when you look at the values, you look that the pH is low, PCO2 is low, so we would assess that this patient's got a primary metabolic acidosis. Okay, both going in the same direction, so I would say a metabolic acidosis. I would look at compensation using a Winter's formula, which is appropriate in this situation. So adequately compensated primary metabolic acidosis. The next step in a metabolic acidosis, we would do an Anion GAP, which is 10 in this patient. So thus, I would summarize that this patient's ABG scenario is indicating adequately compensated NAGMA. Okay, that would be so far so good. However, looking at further information provided in this particular scenario, this patient's pretty unwell and has got a raised lactate level as well. So how does a patient who's got lactic acidosis have a NAGMA? Lactic acidosis is supposed to be under the classification of high Anion GAP metabolic acidosis. But here you got a patient who got NAGMA and has got lactic acidosis. How is that? So that's something we've discussed previously, and on the first video as well, I very clearly explained situations where you could have a falsely low Anion GAP with conditions which are actually high Anion GAP metabolic acidosis conditions, okay, where the Anion GAP could be falsely low. Please have a listen to that particular video, but in subsequent videos as well, we've dealt with this particular situation. However, the first thing you would do in such situation where you have got a NAGMA but you suspect it could be a HAGMA, and the Anion GAP obviously is not raised, you would actually go look for the albumin level to see whether the patient's got low albumin level, hypoalbuminemia, because hypoalbuminemia is a situation where you could have a falsely low Anion GAP. And this patient actually had a low albumin level, and subsequently you correct the albumin level and then correct the Anion GAP according to the corrected albumin. And then the corrected Anion GAP for this patient would come to around 15. So that will tell us that this patient's got a HAGMA, although initial assessment was a NAGMA. Okay. The other condition where you could have a falsely low Anion GAP is lactic acidosis itself. Even though the albumin might be normal, you still could have a low Anion GAP in a lactic acidosis patient 50% of the time. That has been discussed in the first video. Please have a listen. before continuing that particular scenario from the American Journal of Kidney Diseases, I would like to point out that the authors would probably and likely have a different approach. The concept might be similar, but the steps might be different. So I do have a different step process, and their step process might be different. Just keep that in mind. So as explained in the previous slide, we go on to check the serum albumin. Here it was low at 20, so the delta albumin delta difference is 20. So you correct it by factor of 0.25. You get a factor correction of 5, and then the corrected albumin gap is 15. So NAGMA now becomes a HAGMA. The authors of this excellent article conclude that this patient's ABG scenario was a HAGMA with appropriate respiratory compensation. I too agree with that, absolutely, right? But is that all? In that situation, I would very respectfully beg to differ. The author's knowledge is extensive, their experience is amazing, but in clinical medicine, it's okay to have a difference in opinion. That's what makes us good clinicians. So here I will respectfully differ, and I'll explain in the next slide why. Continuing from the previous slide, I respectfully say that I've got a slightly different assessment as compared to what they mentioned. As to why that is and what that is, I would now explain. Now let's say this patient's now we've assessed that this patient's got a high anion gap metabolic acidosis. The next step in that would be to do the delta-delta ratio. In a patient who's got HAGMA, and only in patients who've got HAGMA, I do a delta-delta ratio, and then we find that this patient's values point towards an additional NAGMA. If you do the equivalent methods to delta-delta ratio, which I had discussed previously, also would give a clue that this patient's got an additional NAGMA. So I would say that this patient's got adequately compensated HAGMA plus a NAGMA. Okay, so that would be my assessment. Now let's say that this patient's actually a different approach to let's say this patient, let's say from the outset had a normal albumin level, then your first assessment would have been a NAGMA. Then you would have gone on to look for the delta-delta ratio, right? Then that would have pointed out to an additional NAGMA. So that's what I'm trying to say. Okay, this patient's got a HAGMA plus a NAGMA, and this probably is what the authors also probably had in mind when they said the patient's got a metabolic acidosis compensated, but I've just gone on to explain an additional step. That's all. Okay, thank you. Well done. If you come this far, you would be the boss of blood gas interpretation of the wards. You will be the champion of champions in ABG analysis. Well done to you. I've shown the sites from where I have actually taken many of these samples, apart from ward rounds scenarios as well. And I urge you all to visit this site. This is the anesthesia MCQ.com, the life in the fast lane, ACLS scenarios, the American Journal of Clinical Diseases, kidney diseases, and the Harrison textbook. If you use the method that and the process that we've described, you would reach the analysis, the same analysis that these authors have reached as well. Okay, close to 100 or more than 100 scenarios. I've tried for the purpose of presenting these slides. I've not presented everything. I've selected relevant ones and presented here, but I've tried these on more than 100 scenarios of different authors, and it's worked every time, and it's worked all the time. So I urge you all to try this process and work out in your wards and the samples given with other authors as well. You would be alright. So many people have given so much, and I'm eternally grateful to all of them. Thank you. If you have liked what you've seen and listened to, then kindly hit the like button and subscribe. I plan to do many other topics in the future. Some of them are the anion gap concepts, expanding on them, the urinary anion gap and examples, the osmolar gap, urinary and serum osmolar gap, renal tubular acidosis, renal channelopathies, and many other topics. If you do like, please subscribe. Thank you very much for your time. Take care until next time. See you again. Bye.